Hey, what's up, everyone? How's it going? Welcome to another live show, our Wednesday Live with Nekky Jamal show, and we have the one and only Dr. Glenn Van Ass. How are you doing, my man?
Nekky, it's a pleasure to be here. Sorry for the IT issues,
No problem.
but
You're
I'm
looking
an old guy now, so it's always going to happen to the old guys.
yeah, right. But dude, looks like Santa's on your side here. You're looking very festive today, my friend.
Just finished a Christmas party with the staff, and I've always got to get dressed up, so I was the naughty elf this year.
Oh yeah, well, hopefully they boozed you up during the Christmas party because that'll make for an entertaining live show. Am I right?
I was very good. I withstood countless pressure and was able to make it through unscathed.
Oh, I love it. I love it. But I want the world, even for me, I want to learn more about you. Glenn, you are a titan in our field. You've had, a very extensive career where you've taught around the world. You've taught microscopes and lasers, and you've founded like dental microscopes. Like you are the guy, and I'm so proud to have you on. But man, I want to hear about you. How did you get into microscopes? How'd you get into dentistry? Tell me about your journey, man. Fill us all in.
Well, my dad, who just passed away in May, he was
Sorry, man.
93 years old. He was a dentist, and we practiced for 18 years together. So that's how I sort of got into dentistry. And I got to be honest, the first several years were really not that fun. I asked him, I said, if this is all what dentistry's cracked up to be, I'm not really enjoying it. And so, make a long story short, it was about 7 or 8 years out. I'd actually tried to get into ortho school, and I didn't get in. And my wife said, we want to have a family. And she said, you're not going to get into ortho school, so you better figure something else out. And I was almost to the point where I didn't know whether I was going to continue in dentistry. I just didn't like the unpredictability of it. I didn't like the not being able to see or anything. And it all came to a head. I did an endo on an upper 1/6 on a guy. He was a welfare patient, and he kept saying the tooth was sore. Tooth is sore. I said, oh, it'll settle down. And he went to see a specialist. He opened it up and showed him with the microscope the canal I missed, the MB2. And so he came back, demanded his money back. And he said to me, when he was leaving, he said, maybe if you're doing root canals, you should get one of those microscope things or stop doing root canals. And honest to God, that set me back. I thought I have two choices: either learn how to do endo or get out of it. So I went to Seattle, saw Cliff Ruddle there in 1996, and in
Yeah.
'97 I bought the first scope. And I wondered why at the time nobody was using them for all of dentistry. And I bought one, and then it became two, and then it became three. And in my office now, I have nine. I have one in every room. So
What?
it's really a microscope center practice where I do all my work 100% through the microscope.
Really, man, man, there's so much there. I just got to dive into. So your dad is the one that got you into dentistry. He was a general dentist, and you wanted to be like dad. Hey.
He practiced 44 years. He retired at 77. So I don't think I'm going to make it that long. He passed away in '93. Had a really good life, and we practiced completely different. But he was really a role model to me growing up, and I had the fortunate ability to practice with him for 18 years. So every time, and maybe there's people out there who practice with their dad or his dad's a dentist. It was really a special relationship.
Yeah, no, I don't doubt that. My dad is a huge part of my life too. I'm sorry to hear that he's passed. What does it mean to practice with your dad? Like, what is that like? Like, is
It was
there,
good.
because we
I
always
think
treat
in the
our dads
beginning, he
different.
taught me a couple things. He taught me that people don't really care what you know; they want to know you care. And he taught me that one of the best things you can do is look after your staff, and they'll look after you. And so I've tried to sort of look at those things and make sure that I always put myself sort of in the patient's point of view and try and see it from their viewpoint, because I think he was really good at that. He was a really good role model for how to run a practice and how to be kind to people. And he gave me lots of stories over the 18 years. I was really fortunate. It was really a great time. We worked together, we traveled together, we ran marathons together. So it was a really great working and personal friendship. I miss him a lot. He was a real big influence in my life.
Yeah, you know what? Let's dedicate this episode to your dad. What was your dad's name?
Tom.
Tom. That's amazing, man. We all, as a son, we always have a special relationship with our fathers, don't we?
For sure.
Yeah. So you mentioned another point. You started running. Like, have you always? I know. Glenn is the Iron Manner. I don't know him as the runner. Like, how long have you been getting into this for?
Well, one of the things that happened in about 2017, my daughter's a naturopath, and she was worried. She said, "Dad, you're gonna have a heart attack." She says, "You're really overweight." And I had really stopped. I had done some marathons in 2008 when I was in my mid to late 40s. I did 5 marathons and enjoyed them, but my left knee was giving me a lot of problems, and probably because of the weight. So my wife and her sort of got together, did an intervention, and said, "You got to lose some weight." So I went from 210 down to 160 at the lowest. I'm about 170 now.
Yeah,
And then I started noticing that I could run again a little bit without my knee swelling up, but not 5 days a week. So I started to do some triathlon training. I had to learn how to swim. I didn't know how to swim at all. You and I
yeah,
talked about that a couple of years
totally.
ago, about
Yeah.
learning to swim, and started to ride the bike indoors and outdoors, and did a half Ironman in 2019 before COVID hit in Indian Wells. And that's a 2 kilometer swim, a 90 kilometer bike, and then a half marathon, 21 kilometers. So I'm doing 2 more this year, one in Kona and one in Washington State, if the pandemic holds out. And I don't do it to win. I just do it to enjoy the training and to take the stress out of dentistry and to focus on improving each day.
Totally, man. And Glenn, to be 100% honest, you actually inspired me to get into Ironmans. I'm not much of a marathon runner. 21K is my max. I don't like doing. It's just not for me, man. But I loved training for half Ironman, and then COVID hit, and my race got canceled. But you actually were inspiring me, and you said you were like, Nekky, why aren't you doing this? Like, dentistry is stressful enough. Go
Yeah.
and do it. And you put me on the right training path for swimming, because I had to learn to swim too. And unfortunately, I never got to get my Ironman in because of COVID. But I am going to jump back in the pool. I haven't been in the pool since COVID started, since all the restrictions. So that's awesome. So when's your next Ironman?
Well, I ran a race, so I still try and run
Yeah.
twice a week, and bike 2 to 3 times a week, and swim twice a week or once or twice a week. And so I have in June, I'm going to go to Kona and race in Kona for in Hawaii in the Big Island, do a half Ironman there. And again, like, these things take me 6 hours. I'm not doing it 4 hours, or I'm
Dude,
not setting any
you're doing
records.
it for you. Who cares
Yeah.
about everyone else? You're doing it for you. Hey, Glenn, what do you say to people like me right now who say they're too busy? Like, how does someone dedicate family time, business life, practice life, and then here you are, you're going out and training? How do you balance that? I'm finding a hard time myself.
You know what? It's really hard, Nekky. I mean, in 2017, I partnered with Dental Corp, and neither of my kids. My son's 27; he's a businessman. He's a very successful businessman, and my daughter's a naturopath. So neither of them was going to take over the practice. And
Right.
Dental Corp allowed me a little bit of time to kind of reduce the administrative headaches.
Yeah.
I still do, a lot of clinical dentistry. I'm 50 hours a week, 55 hours a week. So
What?
some
Really?
mornings, yeah. So some
Man.
mornings I'm up early, and I leave here at 5:30, and I head home, and I eat something quickly, or don't eat until I finish an hour and a half of training, and then eat, and then back at it the next day. The weekends are really where it's at. You're when it really comes down, you're doing 4 hours on the bike and an hour running, or an hour and a half running on a weekend, like back to back. They call it a brick. So those are the weekends are where you really put your time in, Saturday, Sunday, and then you go
Yeah.
back at it Monday. And this year, I'm going to work 4 days a week and see if I can, dedicate a little bit more time instead of just the weekends and an hour and a half each day, sort of thing, to train. It's a good way to reduce stress, and you have to set your priorities. I mean, my priorities are practice, and I'm lucky my kids are grown up, so I don't have to deal with young kids like a lot of people do. So it's tough. It's tough when you got young kids.
Yeah. No, I hear that. Glenn, how long you been practicing for?
So I graduated in 1987, so
Yeah.
it's 34 years now.
Wow.
The
Okay. So
last 20, the last 24, uh, since 1997. So what is that? Yeah, 24. So I've been with the microscope fully, but I had 10 years before that where I was using loops.
really, man,
Yeah.
you're gonna make fun of me so bad. Loops gave me a
No.
headache in school, and I
Yeah.
just couldn't get back into it. I pull a lot of teeth now. My ergonomics is crap. I'm lucky. I'm 6'5". I'm lucky my back isn't
Yeah.
broken yet. But I want to get into it. But before we talk about microscopes, Glenn, I gotta ask just for my own curiosity. 34 years behind a patient working. what gets you up in the morning? What type of procedures are like, yeah, I'm doing this. Like for me, I got, 7 or 8 sets of third molars a day. I'm pumped up. Let's go. What's
Wow.
Glenn Van Ass? What's he feeling like?
You know, I think as my practice is sort of aged, I'm doing more adult restorative, and I enjoy. I think I enjoy doing ones and two implants. I don't like doing. I'm not a full mouth guy. I've
I'm
tried
with you.
them, and I don't like it. I just don't
Yeah,
like the surgeries. I hats off to Mark and Bernard and the rest of the Bites
totally.
crew that do that.
Yeah.
For those GPs out there listening, I think it's great if you can. I just don't. I don't like those big bloody surgeries, and I don't do it. So I don't. I like the cosmetic cases. I like I like treating, 1 to 4. The whole upper jaw or the whole lower jaw is not my. I just find it difficult to sit that long looking through the scope at all these teeth. So I like to do, just cosmetic dentistry, implants, ones and twos, and that kind of stuff. That's really what I really, at the end of the day, I'll tell you a story, Nekky.
Yeah.
When I was teaching once in Missouri, a guy came up to me and he asked me if a microscope was good for his practice. I asked him, "What kind of practice do you have?" He said, general practice." I said, how many docs?" He said, "Oh, just me." I said, "How many rooms do you have?" He says, "I got 3." I said, "Okay, well, I'm thinking, 3 microscopes." And he said, "Well, actually, I have 2. I had Genesis 1, and really, I only practice out of 1." And I'm like, "Oh." And I look at him, he's about 50 years old. And I said to him, like, in an average day, how many patients would you see? Because I'm thinking to myself, if he's seeing like 25 patients, he's never going to slow down enough. And he
No.
goes, like, "Me in an average day without the hygiene or with the hygiene?" I said, "Just you, without the hygiene." He looks at an average day, and I said, "Yeah." And he goes, "2." And I said, "You see 2 patients in a day?" And I said, "Are you
Yeah.
happy with that?" And he goes, "No, not really." He said, "If I was really happy, I'd see 1. And I'd cut 12 crowns and I'd go home." And then I started to realize that for me personally, the
Yeah.
stress in my life was linearly and directly proportional to how many times I took my gloves off in a day. So when I went
Really?
through a box of gloves in a day,
Yeah.
it was stressful because it meant that I had to get up out of the chair. I had to go see 3 hygiene patients. I had to
Yeah.
go back in the chair. I had a deal filling on a person who didn't get numb, who wanted to ask me a bunch of questions. I'm looking at the clock. They showed up 15 minutes late.
Yeah.
Those are the days I really go home and I'm just bagged. The
Yeah.
best
Yeah. Yeah.
days are when I have a couple patients, 3 or 4 patients, and I look at the productivity. I'm like, I was way more productive than all those days where I'm seeing, tons and tons of patients. And so I've tried to reduce that. I've tried to make it so I see less patients and do more on those patients, and those are the best days.
Totally. So are you trying to like, if someone has, the equivalent of 3 appointments, you're trying to do everything in one appointment?
No, I like to try and
No.
do, quadrant work, but I try and make it so that I do more on less patients. And the best days I have are a lot of times when I have a sedation patient and I have a patient that's there for 3 hours.
Yeah.
You do a lot of IV sedation. I do a lot of
Yeah.
oral, and I don't do IV sedation. But those patients where I'm doing sort of bigger procedures and I'm not getting out of the chair. Sometimes on Fridays I don't see any hygiene patients. I love those days because
Yeah.
I can sit down in the chair and not be stressed by a hygienist tapping her foot saying, my next patient's here and Mrs. Jones wants to talk about TMJ and bleaching and she's got some questions about her son's orthodontics. I mean, like,
Totally.
on those days I hate.
Tell her I'll call her later, man. I don't have
Yeah,
time for that right now, right?
yeah. So the more you can do on less patients and also, be able to take your time and do quality work. I've always tried to do quality work. And I think that's where the microscope helped me because it allowed me, I still got crappy pair of hands, but I have the best eyes in town.
You do have the best eyes in town. That there's no one that can take that away from you. But talk to me. How does a microscope not slow you down?
No,
Because
it
I
does.
feel
I mean,
like
initially it
how else
does.
can you? Yeah.
Well, I think, what I learned, Nekky, is that with microscopes, there were 4 advantages. And
Okay.
the first was ergonomics. And you were talking about your back. And I'm
Yeah.
sitting upright all day long, looking straight ahead. And from an ergonomic standpoint, I know people who have severe neck and back problems, discs
Yeah.
out, etc., and they don't care about how much they practice. They just want to continue to practice.
Mm-hmm.
If they set themselves up with a microscope, it's probably the best thing you can do in terms of ergonomics. In terms of precision, you have 2 to 20 times mag. You don't have to use 20 times. You can use 2. And yet, with the multiple powers of magnification, if you get into trouble and take off an old crown, I don't know where you're looking. Is that margin? Is that decay? Is that composite that you're sitting on? Is that a crack? All these questions are answered by just turning the magnification turret and bumping up your magnification. I can take lots of video and stills really easily without having to unglove, take a camera. I can take video and stills through the microscope. And because the microscope is attached to video cameras and monitors in the office, the patients can look up and they can watch in real time what I'm doing. And there's a level of trust that's built up there. And the assistants can see what I'm doing. I don't have to talk as much. I hate getting, constantly explaining what I'm going to do next. They can see what I'm doing next, and they can anticipate a lot easier what I'm going to do.
That's a
So
very interesting point.
ergonomics, precision, documentation, communication, those are all things that are advantages.
So your patient is watching in real time as you're doing it?
50%. Yeah, they will. And they've
Really?
watched endos, extractions of root tips. They've watched surgeries. You'd be surprised. They all watched the surgical channel when it used to be on, looking at knee operations and heart surgery. So you'd be surprised at how many people will. And don't kid yourself. When you're wearing glasses or you're
Yeah.
wearing loops, they're looking in your eyes, looking at the reflection, trying to see what you're doing. So this way they don't actually have to squint or, move around when you move. They can actually see what's going on, and a lot of patients like it, and it builds up trust, and they hold still. So that's the best part.
Here, I thought all the ladies were just admiring my eyes.
Yeah, it might be.
No.
Nekky, you're a young guy. Mine are just bloodshot and old and droopy, so they're not admiring my eyes.
Oh, that's awesome, man. That's so I didn't know you could actually like feed your microscope onto the TV so they can see that. So is there any procedures you won't do with the microscope?
Yeah, that's a good question. Even with the like injecting local anesthetic, I'll just lift up the microscope. I don't have overhead lights, so I just lift up the microscope, use the light that's there, put the anesthetic, and pull it down. Um, I know for me, I'm so used to using, I just use it for everything. It's just like a pair of glasses for me. And so I just use it for everything. I won't use it at high mag. Most of the time I'm working at between 8 and 13 times mag, sometimes 5 if the patient's moving around or it's a little kid. But
Yeah.
most of the time I'm working 5, 8, or 13 times mag.
Wow. Okay. So at what point would you recommend if a practitioner is using loops, like say they use, 4 times loops, at what point would you recommend switching from loops to a microscope? Like at
It's a
what
good
level?
question. It's a really good question. What I found is I wrote an article, and it was 20 years ago, and I wrote an article about the magnification continuum. What I found was a lot of people were using 2 power loops, and then they went and got a pair of 3 power loops because they needed it for endo, and then they
Yeah.
would switch between them, and then they got a pair of 3.5 or 4 power loops, and after 3.5 or 4 power, the weight gets quite long, and especially for females with neck musculature that's less, you see a lot of ergonomic issues with declination angles, and that they're having lots of pain in their neck. So I tell people that there's one of the biggest advantages of the microscope, and even for you, is the illumination. The illumination is
Mm,
coaxial, meaning that when you're looking through the microscope, the light is coming through the same angle. So you're not having to constantly adjust your headlight because your eyes are looking one way and the headlight is shining from a different angle. So
right.
with the microscope, because there's so much incredible illumination, it really illuminates things. And people after about 3.5 or 4 power, I say before you go to an 8 power loop or 6 or 5 power,
Yeah.
start looking at a microscope because maybe that's the answer for you.
And
For
is there
you, I
any
tell you get a light.
I do use a light, but not my loops.
Yeah,
Oh man, I'm ridiculous. Hey,
yeah.
what brand of microscope would you recommend? Or what type?
I've used Global. They're out of St. Louis. There are really a lot of great companies now. Zeiss is well known for its optics. CJ Optic is a new company that also is around, and they're kind of out of Germany. And there are other brands too that are less expensive. Knockoff Zoomax is one. There is Leica. There's another couple companies, but I've used Global Surgical out of St. Louis for the last well, whatever, 24, 25 years, and they've been good to me. And it's a company dedicated to a dental operating microscope as opposed to taking one of their ENT scopes or one of their gynecology scopes and telling people you can use it for dentistry.
Huh. And so, just so you know, Glenn, I have a global microscope in my office.
Do you?
And yeah,
Is
like
it a coat rack?
one of my one of my associates use it for endo all the time, and so maybe I'll
Cool.
steal it back and try to pop out some third molars with them. But I should try it out with an occlusal filling and see, like, just get used to it. Hey, like how
Upper
do you?
arch, or even if you say, listen, I've got a patient and I'm not rushing and I got a root tip and I can't get it out. It's amazing. Sometimes if the root tip is right by the sinus and you can see the root tip going like this, it's a lot easier to sort of not push it up into the sinus and get around it. When you get used to looking, you can actually see when you're pushing on the root tip when there's more movement, so you know which direction you can push it out with. There's a lot of
Ah.
little things that you once you've used it for a while, that you realize the microscope offers you such incredible visual information. It really makes it a lot easier in a lot of ways.
And so when you want to start to use the microscope and get better with the microscope, what procedures would you want to start with? Like,
Well,
how
the
do you build your confidence?
upper anterior, because you can do direct vision. So if you're going to do
Ah,
upper anterior, something on the facial of the upper anterior, it's fine. Or if you're trimming a temporary in your hand, anything like that that you're not working in the mouth, then incorporating mirrors after that. And the lower arch, lower molars and premolars, for a variety of reasons, are more difficult to see. So people struggle with those teeth,
yeah.
and there's some different positions you can put the patient in that can help you sometimes. But we offer courses twice a year. The next one's in May in my office, and if patients have a microscope and they're not using it, I encourage them to try and get a hands-on course. And not just mine. There are other people that run courses, and if people want, they can always ask for my email, and I can put them into, connect them with people who are running courses. I know somebody in Virginia that runs courses, somebody in New York, somebody in California. So there are courses available.
Glenn, how long you been teaching for?
I started in '97, and I've done over 900 lectures in over 35 countries. And I slowed down a little bit. Because I'm 60 now, I sort of have made a commitment the next 3 or 4 years to do a little bit more teaching before I slow down, before I either quit completely or slow down. So I'm going to set aside some time to help with Dental Corp has an institute called the DCI. I'm going to try and help with that. And I'm also going to do a little bit of entry level training for people in implants, and some minor stuff for lasers as well with BioLase. So I'm trying to get back into it, but I kind of took some time off with my dad, and I'll try and get back into it a little bit in the coming years.
Now, Glenn, every time I've been to a course with you, and this was pre-COVID, and I'd go to the Bites Institute, and we would be at the same course together. People flock around you because you have just a wealth of knowledge. Don't give me that. You know what I'm talking about. How did you get into lasers? Because that seems to be like, you have two stacks that everyone wants to know about, Glenn: lasers and microscopes. How did you divert into lasers?
Yeah, it's a really interesting question. You were you're talking about people flocking to me, and you were used the word titan, and I kind of laughed because I never did this to really get into lecturing.
No,
I was
but
a tour guide as a kid, going through dental school. I did tours at Britannia Beach, which is near Squamish. There's a mine there, and I did that for 6 summers, and I gained some public speaking confidence and things like that there. But I never started this journey to teach, and so when you say, well, people fly around, they want to know about scopes or lasers or things, I always say that the road to success, Nekky, is paved on failure. And if you're open your
it's the
eyes and,
truth.
and keep your eyes open enough to sort of learn from your mistakes and not just bury them and say it was a patient's fault or the assistant's fault or the lab's fault, but whose fault really was it, and what could I have done to improve? Then you can, you're going to learn from 34 years of that. And after I got into microscopes, the guy that sold microscopes sold lasers. And he came one day and he said, "Have you ever thought about lasers?" And it was in about 1998. And I said, "Larry," I think lasers is an application looking for a purpose. And at that time, argon lasers had two wavelengths, green and blue. And those lasers weighed 210 pounds, and they were $54,000.
Yeah,
So we called it the Zamboni because it was so friggin' big. You couldn't multi-op it or drag it from one room to the other. You had it in
yeah,
one room. So basically, you used it for in that one room. And the blue mode was for curing resins in 3 seconds because we didn't have high-speed curing lights at that time. So you didn't have the ability, and it was cool because you could cure these teeth in 3 seconds. Boom, it was set. And then the
really.
green
All right.
wavelength was a cutting wavelength. It was really hot and it was cutting. And the very first procedure, I bought the laser, and the very first procedure I used was an operculectomy. And I asked the salesman, I said, "Well, this is a 12-year-old kid." I said, what setting should I use? He goes, zero point 0.5 watts. Well, it turns out he didn't know the settings either. So we started at zero point 0.5 watts, and honestly, for about 15 minutes, it didn't do a thing. And the kid kept asking me, "Are you done yet? Are you done yet?" And what would have done like 5 seconds or 10 seconds with a blade, and it would
Yeah.
bled a little bit. It took me 15 minutes. But I stuck with it. I thought I better take some courses. I went and got certified. I got a mastership in lasers from the Academy of Laser Dentistry. And then I found that people weren't really that interested in using the microscope, but there was a real fascination with lasers because people knew of laser eye surgery and they were kind of keen to they'd let you use a laser in their mouth. And they were like, oh, you got
Yeah.
a laser? So I started to use lasers, both soft tissue and then hard tissue lasers. And after I got my mastership, I really kind of separated my niche. As a general dentist, if you want to lecture, you can't lecture about pros or endo or perio because the specialists are lecturing about that. But
Yeah.
there's no specialty in microscopes and there's no specialty in lasers. So I was able to kind of carve out a niche, for how to lecture on those topics, and maybe my background in guided tours at Britannia helped me to feel confident enough to lecture. So
Yeah.
that
Yeah.
was sort of the story on lasers. Same guy sold me a laser that sold me a microscope, and he probably retired after that.
Man, so Glenn, I love it. Now we got to dive into lasers though. Where
Okay.
I have a soft tissue laser. Okay, I use
Mm-hmm.
it. I don't use it that much. My other associates, they use it when they're doing their prosto. Instead of packing cord,
Cord.
they're using
Yeah.
the laser. What do you think about that? Because I think that's the most common use of a laser. Do you think that's a
Yeah, you know
proper
what, Nekky?
application
It's a
for a
really good
laser?
question. I think that lasers can be used, a soft tissue laser like what you have, what
Yeah.
they can be really used for well is minor recontouring of tissue. Gingival troughing, small gingivectomies. They can be used for oral lesions like aphthous ulcers and things like that, or oral mucositis from cancer patients and things like that is a really really powerful thing to use lasers for. Um, they can be used for whitening, and that's here or there. Some people like using it for whitening. But one of the biggest uses, and that's what I think you might be benefiting from, is to use your diode laser without a tip in it and just put a barrier over top of it for low level laser therapy. And for those
Hmm.
who don't know about it, what low level laser therapy is, it's photobiomodulation. And what happens is the laser light's absorbed by the cells, the mitochondria and the cells. It absorbs the laser energy and it really sends the cells into hyperdrive. So you get extracellular matrix, you get increases in cellular motility, and you get really three main things. You get decreases in pain, improvements in wound healing, so it's faster, almost like PRF in the same way. And in addition, what you can do is you can reduce paresthesias as well. So low level laser with a diode, just shining it for about half a watt for anywhere between 30 and 60 seconds can help in a multitude of procedures. And people don't believe me, just look up LLLT, low level laser therapy, LLLT on the net. And every single article now that's done well, every single article shows improvements in wound healing, pain after third molar extractions. Use your diode one of these days. You take out 4 teeth on the easier side, use it for a minute at a time at half a watt on those two, on the upper and the lower, and don't use it on the other side. And then ask the patient afterwards, say, hey, how was it? Are both sides the same? And I said, were the other ones really tough to take out on the one side? And you'll say actually the ones that were difficult were the ones that on the other side because the laser really going to help you. I know you don't believe me, but look
Do
it
you
up.
see
Low
this
level laser therapy.
dumbfounded face right now? Are you shitting
Huh?
me?
No.
This is a dumbfounded face. I had no idea this existed. A lady talked to me about it. She took one of my courses and she was like, Nekky, have you ever heard of
Biomodulation.
photobiomodulation? And I was
Yeah.
like, no. And she's like, dude, you got to look it up. You have to take
Yeah.
this guy's course. I forgot. So you're
Look it
telling me
up.
it's legit. You're telling me
Yeah,
it's
and
legit.
you know what? It used to be all smokes and mirrors, and
Yeah.
every single study now, you start looking up and you go, oh my god, this is really weird. People are even diabetics. They're using it in diabetic foot ulcers where they don't heal. They're using it in that. All the sports teams use it now for all the sports teams use it for ligament injuries because it's really hard for blood flow in ligaments. People are using it for all sorts of things. Even Alzheimer's, you see dementia cases that they're using it in dementia cases and getting improvements. So people go, oh, come on. And I said, just look it up because every single article has the same thing. You
What?
just see it over and over and over again saying positive effects compared to the control groups. Well done studies now. So look it up. Low
I,
level laser therapy and your diode, you'll use it for those patients who are going to call you on the weekend. You'll start using it and you'll find that all of a sudden it really helps.
can you tell me how to set up my laser for this? What do I have to
All
do?
you do is you have most of these lasers have tips that you put in, and you
Right?
don't even need to put a tip over it. You just put a barrier, like a light handle barrier, over top of the hand piece, so
With
you get a
no
bigger
tip in it.
spot size.
Yeah, yeah,
Hmm?
yeah. So
No
you don't
tip.
put the tip in. Okay,
No
okay.
tip.
Yeah, yeah.
Just use the bigger spot size, and the barrier goes over top, so you don't get blood
Right,
inside the handpiece on the
right.
laser module. And that's all I do. And I use it at a half a watt. And there are lasers like Zolar makes a laser that it's built in. BioLase has their Epic Pro, and it's also built in the low level laser therapy. But if you have a diode kicking around and you're looking at, you don't have PRF, or you want to try and help with a patient who you worry is going to really have it suffer afterwards, instead of dexamethasone, try the low level laser therapy, and
You are
it really
blowing my
does
mind away
some.
right now,
Huh?
man. You're
Yeah, you
blowing my
will
mind away
try
because
it.
I trust you. Whatever you say, I trust because I know you've lived it,
I'm not
and you're
lying
not
to you.
selling me anything. I know you're
No,
not
I'm
selling
not.
me
I'm
anything.
not
I
selling you
love that.
anything, and it's one of the greatest kept secrets. And your diode at low level will really be beneficial. 810 nanometer diodes are better than 980s or 940s. The best is the lower wavelengths are better, but try an 810 diode, and
Eight
it's
ten.
great.
I'm writing all this down. 810, and then is it pulsed or non-pulsed?
Just continuous wave, half a watt,
Continuous
and
wave.
for
Wow.
anywhere from, some people like 40 seconds if they want to improve wound healing, and 80 seconds if they want to decrease pain. But 30 to 60 seconds, try it on one site, just wave it over the site, just slightly out of contact, slowly moving it around, and then make sure it's at half a watt so you don't cook the tissue, and you just get the improvements of low level laser therapy.
And are you going around the site? Are you trying to get
Yeah.
it in the
So I have
socket?
big flaps. If you're doing big surgeries or things like that, and you got a patient that swells a lot, I'll do it a lot to try and reduce discomfort for them,
And
just
is it
around the site, on an extraction site, around the extraction buccal, lingual, and over the occlusal.
before or after you suture?
After you take the tooth out.
No, but after you suture. So after you've closed your flap or before
Oh
you've
yeah,
closed your
you can do
flap?
it if you're going to do it on third molars after you close your flap, then and everything's all done. It'll also help you a little bit with coagulation, right? Because diodes are well absorbed in hemoglobin, so it'll help you a little bit with that.
Glenn, out of all of the 10 live with Nekky Jamal episodes, this is it right here. This last 2 minutes is all worthwhile. I am
Everybody
so
always
pumped
asks
up,
me that. I
man.
lectured at Dental XP, and they had 1,000 people, and that's all I got the questions on. The American Academy of Aesthetic Dentistry, same thing. Everybody wants to know. I say, wait a minute, I got a diode kicking around. You're saying I can use this? And I say, yeah, and look it up because I'm not lying to you. So
Oh,
you start
man.
using it, and then you start
Yeah.
using a lot because you realize that patients will say, I didn't have any pain. Last time you took out a tooth, I had a lot of pain. This time I don't have any pain. I don't have any swelling.
What?
Yeah.
Man,
I,
Glenn, that's amazing.
yeah.
Holy
I'm
shit,
not
man.
kidding you.
I'm pumped up. You know what? Let's screw this. I'm going to go take out some mates right now, and I can't wait to try this tomorrow. I am pumped. So I'm going to do that. I'm going to do left side photobiomodulation, right side just normal, just PRF.
Yeah.
And I'm going to
And
call every one of those patients, and I'm going to find out. This is phenomenal.
and do it on. What I would do is, as it takes 30 seconds to a minute, do
Yeah.
it on the side that was more difficult, and see if
Okay,
the
okay.
patient says that the other side was more sore.
Yeah, yeah, yeah. All right, this is phenomenal, man. That is amazing. You saved my day. Okay, so we got photobiomodulation. What else am I using with my diode laser?
But diode lasers, like I said, oral cancer now, all these mucositis cases, that's what they're using. They're all buying diodes for that. And I've had experience with patients, who have problems like that. And the PBM or the photobiomodulation can also be used for those patients where you're doing a paresthesia or you're doing a block, and you
Yeah,
get patient phones and my tongue's still numb.
yeah,
And then they come back and you say, oh, I'm just going to map out the area of the tongue. And they go, well, are you going to do anything to help improve this? No, time. We're just going to wait.
yeah, yeah,
We get them in for 5 minutes, use the laser both on the injection site and on the
yeah,
area that's numb. And
yeah.
often when I'm doing it for a couple minutes, they'll say, stop, stop. They'll put their hand up and I say, what's going on? They said, it's tingling right where it's numb. And I'm doing it over the injection site where the inferior alveolar nerve is. And they'll say, stop, stop. It's tingling. I've used it on Bell's palsy patients as well, who have Bell's palsy or nerve damage. And even if it's long-standing, you will find an improvement in it. So people kind of look at me and go, I'm telling you, it can help you in those cases where you have a numb tongue and the patient's super upset and you're telling them it will heal with time. I
Yeah.
don't charge them. They come in and I use the laser on them. Same thing. No tip, just a
No
barrier.
tip. Point 0.5 0.5 watts.
Yeah, sometimes I'll up it. I'll up it if, to up to a 1 watt, but you don't want to go too much higher than that because then you start to overdo it.
Man, that is absolutely amazing. Can you talk to me about using lasers with like traumatic ulcers or aphthous ulcers?
Yeah, you know, it's the same sort of thing. You know what they're
Okay.
doing is they're using it with the low level laser therapy. So a lot of times, if they have an aphthous ulcer, an oral lesion, I'll use it with at zero point 0.6 watts continuous for 45 seconds, zero point 0.7 watts continuous, zero point 0.8 watts. We don't charge them if they come in and say, you know, I got a cold sore here and it started in the last 48 hours. If it's beyond that, I don't do it. But if it's in the
Yeah.
first 48 hours or at best in the prodromal stage, they said I was going to cancel because I got a lot of I got a lot of tenderness here and it's starting. That's the
Yeah.
best time to treat it. Don't charge them. We get patients who come in actually because they have an oral lesion. They phone and they say, "Can Glenn do it?" And then we charge them. I can't remember the fee. It's $50 or something like that
Yeah.
for them to
Yeah.
come in, and it takes a couple minutes to do.
So will you start with 0.5, then 0.6, then
Point
0.7?
0.6. You can start with 0.6 for 45 seconds, 0.7 for 45 seconds, 0.8 for 45 seconds, and that's about it. 2 minutes is enough once. If you keep doing it, it overdoes it. So yeah, if you're getting cold sore and it's just starting, or an oral lesion, denture, sore spot, and it's recent, anything within 48 hours, you can help improve that.
And they're all with no tips.
Yeah, I don't use it. You can use it with a tip. If it's small, it's kind
Yeah.
of beneficial to use it with a tip. The tips
Yeah.
cost money.
They do.
So
Yeah.
if you don't use it, if you use it with a tip, you got to use a little bit lower settings. If you use it without a tip, a little bit higher settings, because the beam size is bigger and your power density is less if you don't use a tip. So if you use a tip, lower the settings a little bit, and if you don't use a tip, raise the settings a little bit.
Wow. Man, I can't wait to use my laser tomorrow. This is wicked. This is wicked. You're pumping me up, Glenn. Okay, so that's the dialed laser. Talk to me about hard tissue lasers, because I've always
Yeah.
been a little nervous to jump into that.
Yeah, you know what? And I agree with you. A lot of people were sold a hard tissue laser on the basis of doing cavity-free anesthetic-free
Yes.
preparations. And you and I talked a little bit about this. And I only do rarely some kids, but I don't like to do it because what happens is if it works on the kids and the kids sit still, then they tell their friends, and then they're all, next thing you know, I'm getting all these really scared moms with their kids who don't want an anesthetic, and then I have to talk the kids into it in occlusal, and it takes longer. It takes 2 to 3 times as long as cutting with a burr.
Yeah.
So I typically will do some kids, rarely, but a lot of buccal class 5s. I can do buccal class 5s without it, and that's it. So I don't do a lot of restorative dentistry. Where I do use it a lot is for removal of veneers and removal of crowns. It really works well. Nobody likes to cut off zirconia crowns.
No. So you
Often
can
in
get
3 or
off a
4
zirconia
minutes.
crown with a
Yeah.
laser.
And E.M.A.X veneers, anything all ceramic, no porcelain fused to metal, no gold, but anything
Right.
ceramic, I can often get off. I would say crowns I can get off 80% of the time, 80-90% of the time. Veneers
Yeah.
I can get off 100% of the time.
Really?
Yeah, and
So,
fast, under a minute.
so like they just pop off, or you're cutting it in half?
Yeah, if they're feldspathic, if they're porcelain veneers, and they were done, they'll crack. They'll crack as you're using the laser, and the pieces will come off.
Yeah.
E.M.A.X, I've done it before, where a person's got bonded on a. I had a guy come in. He was from another dentist. 4 veneers in the front, one came off, and the associate bonded it on with an opaque cement.
Right.
So he said, now the guy's giving me grief because the one doesn't match the other 3.
Right.
So I popped it off for him, cleaned it off, and then he put it on with a clear thing. The funniest part was the guy said, I actually like the color of the opaque one better. Can you take the other 3 off and put opaque cement on them? I said, no, I can't do that. But
Yeah.
anyway, yeah, you can take veneers off, very predictable. I've done it where I've had, patient who something moved or didn't sit right. I've taken it off. What I do sometimes, Nekky, you'll like this one, is if I have an upper lateral that's missing,
Yeah.
you sometimes do a single wing Maryland bridge, like
Right.
say from a canine.
Yeah.
And I do that in E.M.A.X. And what we do is when it comes to, we use those as temporaries, and we take off 2 or 3 times during the process. So we're going to build up the ridge. So the kid doesn't want to wear an E.M.A.X. Or doesn't want to wear an Essex retainer, doesn't like
Right.
that, with that. We'll do an E.M.A.X. one wing on the back if they have room. And then when I need to, I can just use the laser, pop it off, put the implant in, put it back on if I don't want to do a temporary.
Really?
So I can reuse the veneer, the E.M.A.X. I do that quite a bit, and I can get it off in one piece, take it off, it doesn't break, glue it, clean it all up, porcelain etch it, put it back into place again. So those kind of things it's really helpful for.
That's absolutely incredible. I had no idea that was even possible. But so what about like you said, the restorative, to do a 1/6 MO? Is it happening with the laser?
No, I wouldn't do it. I never do. Yeah, it's just I did it in the past, but the problem is a lot of the patients that come to see you are needle phobics, and they
Yeah.
require a lot of management. And I have patients who come to see me knowing that I have a laser and say, can you do all my restorative? And I look, and it's a nightmare because it's under the soft tissue. The soft tissue needs refinement. They're moving around, and some people you can get pulp exposures almost, and they're not moving. And other people, they still don't like the feel of it and the sound of the laser and the popping. So I don't do much restorative dentistry. Crown lengthening, veneer removals. I do a lot of decontamination in extraction sockets with it. It removes the granulation tissue and kills all the bugs.
Really?
We do some work with peri-implantitis cases. So I use it for that kind of stuff. I don't use it for restorative as much.
And that brings me to my next point. How do you clean an implant surface with a laser?
So if you're talking about, we have a whole lecture on peri-implantitis, but when you're talking about peri-implantitis, if you've got more than 50% bone loss, take it out. Okay, it's
Absolutely. Yeah.
I always say, do you know what the difference between a failing implant and an ailing implant is? Have I ever told you this?
As long as it's not yours, it's a
Yeah,
it's a
so it's an ailing implant if it's yours. It's a failing implant if it's done by Nekky Jamal across the
that's
street,
right.
right? But if it's beyond 50%, it's
Yeah.
not ailing. It's failed. Get it
Right.
out. If it's 20% or 30%, a couple millimeters, and you want to try, a diode is not a great laser for it. It heats it up. It doesn't get the granulation tissue out.
Yeah.
BioLase and some companies, I don't know the other hard tissue laser companies, but BioLase makes two tips that fire either completely sideways, they call them radially firing tips,
Yeah.
or they have a chisel on it and it's called a side firing tip. So you can put it in the pocket and it will direct the energy towards the threads. So you can actually angle it in the pocket with the surface the right way. It even has a little pointer on it, and you can go around and get access to it. If you can get access to it, you can leave the crown on. If you can't, then take the crown off,
Yeah.
go in, clean it out. You can get all the granulation tissue off. For most people, if it's not early and really early, you're best off to flap it so you can see what you're doing. And instead of using an eye brush, one of the things is there are studies done in JIPRD, and if people want to know, I can send you the articles. But there are articles done also in Japan where they show not only can you remove the granulation tissue, but you can get re-osseointegration onto the implant. So that's been shown many times.
Wow.
Yeah,
That's incredible.
that's what Mark always says. Mark and Bernard, God love them, and I left Bites a few years ago because when my dad was so ill, and I still have a huge part of my heart for Mark and Bernard because they have done so much to train GPs on implant dentistry. And Mark always says, the big key is to try and get that surface clean. And you can do it with an eye brush, but it's hard to decontaminate that with traditional means. There's guys like Frome that have 6 steps with saline and air abrasion and tetracycline and citric acid, and they're throwing everything at it, the kitchen sink, to try and
Yeah.
disinfect it. And we're just using laser energy with water, and it shows that you can get reosseointegration.
So you've had personal success using your
Yeah,
laser
I've
to
had I've had cases which were my own, not the
yeah.
failed ones, but the ailing ones.
Yeah. Yeah.
And early on you can get success, and sometimes you have to gain access to the site by taking the hardware off and going in there and removing it. And other times you look and you go, oh, you know what, this has got so much bone loss. Let's just take it out and start all over again. I had one today
Yeah.
that the guy started 5 months ago or 4 months ago, and I tested with ISQ and it was 40, and I thought, oh, I must not have it tight enough. Put another peg in, 40, and I took an X-ray, and it was complete fibrous encapsulation. So
Yeah.
it was mine, and I'm going to have to take it out, clean it all out, and start again. And
Happens
honestly,
to
the
all of
gut
us, man.
lining is bad when that happens.
Yeah.
It's not good.
It's almost like the curse of Van
Yeah,
Ness.
yeah.
Tell me about the curse. I want to hear the true story. We've all joked about it. How did you get implicated in the curse of Van Ness? I got to hear this.
Now, when I was teaching at Bites Institute, I was kind of, one of the things is I felt some of the students were more knowledgeable than me. So Mark and Bernard, I learned so much from them, and I really admire how, both the way their teaching style, what they've done with Bites. But I
Absolutely.
asked Mark almost sheepish one day. I said, Mark, can I ask you a question? And I said, listen, I had a couple patients now that I have 3.5 millimeter Hyosin implants, ET3, and I put one in and I looked with the microscope and I thought, what's that dark line on the shoulder as I put it in? And I felt something give. As I was putting it in, I felt something give. And I looked and I thought, did that just crack? And it was a hygienist actually, and I thought, I don't feel comfortable. I'm going to take it out. And I took it out, unwound it, and this is on the day of the surgery. Took it out and looked, and sure enough, there was a fracture. And I thought, I must have torqued it too hard. But probably a couple weeks later, I had a guy come in with a big bubble on his front. It was a 2.4, and it was a 3.5. And I thought, what the heck? And then I thought, why is that bubble, the fistula there? You know, the rest
Yeah.
of it looks okay. And I actually took the laser and cut the gum tissue back, and there was this crack line going up with the microscope. And I thought, you know, this is too coincidental. It's 3.5 millimeter. And I asked Mark, and he said, no. He said, I've never had a single case, Glenn. He said, you know, maybe you're doing something wrong. And I said, Mark, I don't know. I probably am, because you know you haven't had any, and if you haven't
Yeah.
had any, you're the guru. And then all of a sudden, the next study club, he comes up to me and he goes, Glenn, you know what happened this week? Twice. And he said, I got these fistulas, and I'm like, damn it, it's the curse of an ass. And then
Yeah.
next thing you know, Bernard's like, oh my God, Vanass, you breathed on me. I've got the curse of an ass too. I've got a bunch. Now Mark, he does so many implants. I think he had 60 of them that
Yeah.
fractured. So he called. I guess it's better to be known for something bad than not to be known for anything at all, Nekky. And that's the
Yeah.
way I look at it. And I think it's funny, you know, that Mark calls it the curse of an ass, but it's a legit thing where the internal connection is so small, the shoulder is so small. If you torque it in, or if when we used to use UCLA abutments, if they came loose, they would just move back and forth, and the implant would fracture. And once it fractured, it's a bear to get out sometimes. You know, Mark shows
It
these beautiful
is.
cases, but they're not always that way.
No, man, mine are brutal. When I had to take, I had about 7 or 8 fracture on my own patients, and they're brutal to remove if that that ET kit doesn't grab onto that implant and reverse torque it.
It's an
It
extraction.
spreads it further. Oh,
Yeah,
absolutely,
it's a
but it's a
bony extraction.
brutal
It's troughing
extraction.
the whole buckle and pushing it out through the buckle. And oh my God, I mean, I'm not a skilled surgeon like you or like Mark and Bernard. So you know, I feel afterwards sometimes, even after I graft it, that I'm looking at a bridge instead of an implant there. So it's
Absolutely.
embarrassing, and it's you know it's never the dentist's fault. The patient was grinding, right?
That's right. But you know what? In all fairness, I think a lot of the scenarios that I did get a fracture in were my fault. I was using it where it shouldn't have been used. Like they're not made for centrals, they're not made for premolars, they're definitely not made for canines. They're made for lateral incisors and lower incisors. And I
Yes.
think we were pushing the envelope.
Yep. Yep. And I think what happened at that point too, we weren't as comfortable grafting. I know, you know,
That's
I don't
right.
do as much PRF as you guys do, and you guys are doing wonderful things with PRF and putting bone in and feeling much more comfortable with doing this. And you know, I watched the last one with Mark and talking about the Santa technique and just the techniques that people are doing to get build bone now. I think sometimes we were just trying to squeeze things in with ridge splits
That's
and
right.
you know narrow implants and came back to bite us.
Yeah. But we were trying to have the smallest implant possible to maximize the graft space, right? So
Yep.
as we know better, we do better,
Yep. No, you're
right?
right. You're right.
Yeah, I still get a chuckle because every time I do see a patient with the loose crown, the first thing that goes in my mind, the curse of Van Ness. So
Yeah.
that's awesome. Glenn, I learned an absolute ton. It was an honor to catch up with you and photobiomodulation. I cannot wait to try this on my patients, and I'm going to do it on 50 patients, and I'm going to post my cases right on Begin. And dude, I can't thank you enough. Thank you so much for coming on the show, my friend.
Yeah, Nick, you know what? I think it's really cool what you're doing. I watched Alan Gagnon's great one last time, and you know he talked about his journey from aesthetics to soft tissue surgery and tissue being the issue, and I think it's really great because you learn a lot from other people's journeys, and
Yeah.
and I think it's great to give people a chance to tell their story. I'll leave you with a thought that you know as you get towards the light at the end of the tunnel, and you hope it's not a train, you start to realize that you're you know for better or for worse, the majority of your life's behind you, and you think, okay, what am I going to do in the next 20 years? And you want to try and stay relevant. You want to try and share some of the mistakes that you've made over the years to try and help others. And I think these podcasts and the ability for people to tell their sort of stories can really help others feel like, one, they're not alone. Two, that we all make mistakes and we learn from them. And if you do live long enough and you do learn from your mistakes, you get better. And it's really good to just learn about other things outside of dentistry, because it can consume us. And in today's pandemic world, it's difficult out there. For you, the docs that are listening, I feel you, man, because the triathlons have helped me a lot. But man, it is not easy. So keep your head up, keep positive, learn from your mistakes, and just treat your patients the way you would want to be treated yourself. And you're going to be successful, and you're gonna be happy when you come to an old gray stage like me.
Glenn,
Besides, I know as the naughty elf who's going to get presents this year, Nekky, and you're on the good list. So
you know what? I'll
you
take
should
it.
be happy. You should get what you want this year.
Glenn, I don't care what you say, you're a titan in dentistry, and I truly feel so. Thank you so much for coming on the show, and everyone, show Glenn some love, and we'll see you guys next week. Thank you so much, Glenn. Have a great week.
Nekky, thank you, man. Take
No
care,
problem,
buddy.
buddy. We'll see you later, man. Have a good
Bye.
day. Bye.
You too.